Hi, my name's Claire Pryor and I'm one of the senior lecturers at Northumbria University in adult nursing, and I wanted to talk to you today about something I feel extremely passionately about, which is delirium superimposed on dementia. So when somebody has an established or pre-existing dementia, unfortunately gets a delirium at the same time. So the first thing I think that's really important to understand is that dementia and delirium aren't the same presentation. Although they share some clinical features, the exact pathways aren't understood in delirium as of yet, and it definitely isn't the same as dementia. So dementia is an umbrella term that's given to many different presentations to do with memory, which often comes from a disease or an injury on the brain. So the brain being the main organ that's affected. So it's a bit of an umbrella term. There's many different types of dementia, and there's many different presentations and progressions of dementia depending on the type. But as I said before, it's normally categorized to do with its injury or disease process in the area or the region of the brain that's affected. What we do know and what we do have is a consensus that dementia is unfortunately progressive, normally slow for any changes to be undertaken within it, and it is largely irreversible. Delirium, on the other hand, is classified or can be discussed as a state of mental confusion or an acute confusional state. The way that I like to think about delirium is acute brain failure. So we need to start thinking about delirium as the medical emergency it is. If we said acute heart failure, acute respiratory failure, we can sense that urgency, that medical emergency. When we say delirium, sometimes we don't even say delirium, we say they're a little bit more confused than normal. That sense of urgency is lost. Think about it like acute brain failure. Your brain is acutely unwell and there's things going on within that brain which we don't quite understand. We're doing some excellent work looking at inflammation pathways, chemical pathways within inside the brain, but we do know it's an acute failure of the brain to function as it normally does. So we need to really start thinking about that rapid action and what that rapid action should undertake for the person, the medical emergency that is delirium. So the exact etiology, like I said, of delirium isn't well known at the moment. We are making leaps and bounds in getting to understand it. We know, though, that delirium presents with sometimes what people say is an altered state of consciousness for that individual. It might be that their perception or cognition changes acutely. And we need to think about that word consciousness, really splitting it down into the person's level of attention or level of awareness or their arousal to the environment and the situation around them, to really start pulling apart what do we mean by an altered level of consciousness. So it's looking for that acute change. Is something different in my client, my patient, my loved one, my family member than what I normally understand them to be like? Unfortunately, delirium is extremely common. And there's a few studies that have shown that 50% of people in hospital at any one time, if they're over the age of 65, will have a delirium at some stage. We know that it is fatal and there's a significant risk of increased mortality post-discharge. And whilst we talk about delirium as being rapid in onset, it can persist for, now we understand, 6 months or more. Sometimes it's weeks, sometimes it's days, but you can have persistent deliriums. 96% of all cases of delirium occur in older people. And as we can see there, it has a poor prognosis and it can be fatal. But unfortunately, it's not a disease state in itself that we can pin a specific treatment for a disease on. We have to think wider about how we treat delirium. So what does it look like? In somebody with delirium, and this is for everybody with delirium, but really it's a good key to look for in somebody who has a dementia. Are they suddenly more hyperactive than normal? And the key for somebody who has a delirium on top of their dementia, so a delirium superimposed on their dementia, is that really robust, well-crafted, careful history taking to find out what that person's normal being, their normal presentation of self is. Are they suddenly more hyperactive? Are they often getting up and walking around? Are they driven to walk around much more often than usual? Are they the kind of person who likes to sit in their chair and watch the garden or gently potter around the house, and now all of a sudden they're up and they're walking and it's hard to get them to kind of stop still to have a drink of water? Staff often recognise this type of delirium, especially in somebody with dementia, because it seems shocking and it seems new, and quite often we have to do more things for this person to maintain their safety and their well-being. The other type of dementia, delirium superimposed on dementia, and delirium in general, we see is hypoactive delirium. Now, staff don't often recognise this type as much because it often gets misconstrued as, oh, they're a bit sleepy, they're having a bad day, they maybe have a UTI or a chest infection, and they're just a little bit lethargic because of that. Unfortunately, what we're doing there when we kind of normalise this hypoactive state is we're missing the medical emergency. The same acute brain failure that's happening to the person who's driven to get up and walk around is happening to the person who is sleepy and isn't wanting to get out of bed, or you can't really wake them up to get them their breakfast. It's the same condition, it just is manifesting in that individual slightly differently. And sometimes we flip-flop between the two. So we have mixed deliriums where we do recognise this again, and it's because it's quite pronounced, seeing somebody suddenly being hyperactive and then later on in the day being hypoactive. We categorise it really depending on the most prevalent state, but it is about watching that person change throughout the day course. So a little top tip, remember, think about that person's level of awareness, their arousal or their attention to the environment around them, and ask yourself and ask other people questions about, is this normal for how we understand this person to be when they're well? Has something happened? Dig back into the history. As I mentioned before, delirium in general can persist for months now. So speak to the family, speak to the carers, and ask, was there some event, was there an occurrence that happened that kind of triggered this change in behaviour? Was there an acute change in behaviour and we've been very hyperactive or very hypoactive since? Because although we know delirium normally comes on in days, it can last for months. So unless we have that careful history, we might miss that identification trigger in their history. Last week when they had awful pain or they went in for some surgery, that's when this all started. There are some formalised assessment methods that you can use, which are very, very helpful in delirium in general, and specifically some of them have been validated in delirium for people who have dementia. The confusion assessment method is obviously out there and it's very, very well validated and well used. The 4AT is a fantastic tool that is becoming embedded in clinical practice, which anybody can use. There's no specific training required for it. And if you go to the 4AT website, the information is there for you to download and look at very, very easily. And it has been robustly validated in many, many different settings. And the other one is the single question in delirium. Is this person different? Asking that one really focused question, are they different? Is their presentation different to today? So it's really hard sometimes in delirium superimposed on dementia to extrapolate out what is the overriding cause for concern. Is it that somebody who has dementia has a presentation that needs some heightened skill to be able to manage appropriately? Or is it that actually this person with a dementia has been looked after and cared for extremely well? We know them as an individual very, very well, and something's changed. Don't be scared to say the D word when you're taking that careful history or when you're speaking to your colleagues and peers. Say the D word. Don't let it be the elephant in the room. Ask the question, could this be a delirium? The nice guidance is that if there's any suspicion of delirium in somebody with dementia, or if there's an acute change, you treat for a delirium first. Okay, so rather than saying, oh, they're a little bit confused, but they've got a UTI, have they got a delirium caused by the UTI? More often than not, it's going to be a delirium. It might not be a UTI. It might be a delirium coming from one of many different causes that person could have at the same time. Are they well hydrated? Are they constipated? Have they got pain? Is there a metabolic disorder happening within that person's body that we don't know about because we're saying, oh, they're just a little bit confused? Say that D word. Make sure you raise that potential for the medical emergency that acute brain failure is. We're not asking you to have a diagnosis or for you to make that diagnosis if that's not within your remit of practice. We're asking you to start the conversation, recognize the possibility of a clinical condition happening within that person. One of the ways that I think is really useful to extrapolate out the difference between a delirium in somebody with a dementia or whether it is the dementia itself is to use the mnemonic OCD. O is for onset. Delirium comes on quickly, days or hours. Dementia doesn't. It's normally a longer process to recognize that something has changed in that individual. It could be over months or years. C is for the course of that person's presentation. So in delirium, and especially delirium superimposed on dementia, we would be looking for those psychomotor fluctuations, hyperactivity, hypoactivity, or flip-flopping between the two. Generally in dementia, like I said, whilst their presentation might change, it's slow and it's normally on a kind of a slow trajectory, not sudden changes in that person's behaviour or presentation. And D is for duration. Delirium often lasts weeks or months. Dementia is, like I said before, largely irreversible and will be a continuing process going over years. So it's looking for that acute change, looking for those fluctuations, playing Sherlock Holmes, asking for that clear history. And if somebody has changed in their presentation and they are now more hyperactive, more hypoactive, and they've got their dementia as well at the same time, play Sherlock Holmes, go hunting for those clues about what the underpinning condition could be that is causing this acute brain failure. Remember, infection, inflammation, pain, hydration, nutrition, metabolic disease or disease processes. You have to start hunting. Don't just always think it's a UTI. It could be, but it might not be. And don't just think because you found one thing, that's it. Sometimes, especially in people with dementia, you might find that there's 2 or 3 of these known triggers for delirium presenting in them at the same time. I know sometimes it can be very, very hard to start those conversations. So I found this on the RCN website, and it's 5 points to think about and 5 points to discuss about someone you think who might have a delirium. Think about framing your conversations. Has your patient that you know very, very well suddenly become more sleepy? Has their thinking changed? Has their perception changed? What is their function like in their behaviour? And what I would advise doing is always end it with a sentence like, this is different for them. So, for an example, Betty has dementia. We know her very well, but I need to get someone to come and do a review. And I'm going to say, Betty's not as alert as she is usual. I'm finding her really hard to wake up in the morning. This isn't normal for her. She's normally up and about. But when she is awake, I know that her responses to my questions are becoming more slow than I would usually expect her to respond to me in. I think that she might be seeing things which she hasn't had before. And really, her mobility has acutely changed. Her functional mobility has really got worse over the last couple of hours or days. She seems withdrawn, and this isn't normal for her. I suspect Betty's got a delirium superimposed on her dementia. And that should really start to trigger these thought processes of, it's an acute change, it's not normal for them, something's happened. Have we got a medical emergency? Is this an acute brain failure that's happening in this individual? So I'm going to try and play a little video here for you, which really helps pull all of that together about delirium superimposed on dementia. So thank you ever so much for listening to me. And if you have any questions, do just get in touch with me and ask away.